Okay, so in the last few sections, we're going to talk about spinal conditions in children and young adults. So first of all, spinal cord injury is usually due to some kind of trauma. That can be from a penetrating injury, from a rotation injury of the spine, from sudden hyperflexion or hyperextension. So think about that. From axial loading, which is vertical compression. MVA is the most common cause of spinal cord injury. So what happens in spinal cord injury, those are traumatic causes. We can also have spinal cord injury from inflammation. We can have so much swelling and inflammation that it affects the perfusion to the spinal cord or to the nerves. We can have ischemic injury, like similar to a stroke, but we have ischemia to the spine. And then there can be compression from either tumor, hematoma, something like that. So the patho, what happens in a spinal cord injury or what the long-term effects are, depends on the location of the injury. So remember when Mr. Ant taught you about the dermatomes. So the location of the injury is going to determine what parts of the body are affected, but whether the injury is complete or partial determines the severity of that and what the effects are. So if we have a cervical spine injury and it is complete, that person would have flaccid paralysis from the point of the injury down. If we have a thoracic injury, and it's complete, they're going to have flaccid paralysis from there down. But if there's a partial injury at one of those levels, they may still have some sensation, but not complete. They may have some movement, but they may not have good control of that movement. They may have muscle spasms and neurogenic pain in those areas. So there's a lot of different things that can happen with a partial injury. So in the initial time period after a spinal cord injury, there's something called spinal shock. It's caused by edema and ischemia of the spinal cord. The person will have flaccid paralysis and no reflexes. They have no sensation. They develop autonomic dysfunction. They're not able to regulate their blood pressure, temperature, bowels, or bladder. This is a neurogenic shock. So that needs to be treated like shock to try to maintain perfusion. As that swelling decreases, if the cord is not completely transected or if there's some incomplete injury, then the spinal reflexes return, spasticity increases, and neurologic function returns. But you don't really know until you get out of that initial spinal shock time period. You don't really know how much function is going to come back. There's something that happens with patients who have spinal cord injury, and it happens in this initial spinal shock period. But if they have a cord injury and then later on, there are certain events that can trigger this to happen again. It's called autonomic dysreflexia, and it might be triggered by some kind of visceral nerve transmission. So there's some kind of something is distended or irritated. So this can happen with the full bladder, a distended bowel. It can happen in labor. So a person who has a spinal cord injury who is pregnant, they may not feel contractions, but those contractions might trigger autonomic dysreflexia. So the impulses are sent, they're blocked by the lesion to the cord, and that triggers the sympathetic nervous system. So that patient will have flushing, they'll have a sweaty forehead, their pupils constrict, they get hypertensive, bradycardic, and their head hurts. Okay, so it is autonomic dysreflexia can be dangerous because they can have unstable hemodynamics from it, but usually there's a visceral cause, and when that cause is addressed, it's improved. Management in the immediate time period after spinal cord injury, ABCs, airway, breathing, circulation. To open the airway, we don't want to move the spine if we suspect a spinal cord injury, so the jaw thrust is used to open their airway. The spine needs to be stabilized. Emergently, with collar, backboard, etc., if there's a suspected cord injury, if that patient doesn't go directly to surgery, they're going to go to ER. They're going to have X-rays. If a spine injury is confirmed, then that spine has to stay stabilized until the bone heals to prevent cord injury or worse cord injury. So if they can't go to surgery right away and they have cervical injury, they may actually be in Gardner-Wells tongs. It's like a tong, pins are actually attached to the skull. Okay, and it's like, it looks like tongs are put on the head. So this is kind of a halo or a halo type device. And then a weight is hung over the end of the bed. That's to maintain space to help prevent spinal cord injury. That is a temporary measure until that patient is stable enough to go to surgery for repair. They may also place, and this is a more long-term stabilization, they may do a halo vest. A halo vest, if you've seen Mean Girls, you've seen Regina George in the halo vest. The vest part is usually plastic or silicone, and it has bars that connect to a halo that is, again, secured by pins into the skull. So it keeps the skull, or it keeps the skull and the frame of the body in alignment to keep the bones of the cervical spine in alignment. It is very, very important that that doesn't get shifted. I have actually a horror story from one of my first jobs. They were placing a halo vest. They kept the patient overnight. The next morning they had X-rays. The X-rays showed that the bones were sublux. They were moved out of alignment. So they had to go back to surgery, fix the bones again. That happened about 3 days in a row. And then I walked in and saw the transport tech pulling the patient up by the bars to place the X-ray tech pulling the patient up by the bars to place the X-ray plate behind the patient. So it's a staff education issue also, and it's really important that they understand that those bars are not for mobility, they are for stabilization, and we can't be pulling on them. So we also assess for other trauma, because if they have enough trauma to break a neck or back, they may have other trauma. IV methylprednisolone decreases the inflammation, and so it is frequently given in the initial days after an injury to try to prevent further spinal cord injury. They may have surgery immediately if they're stable enough to decompress the spinal cord, get anything off of it that's putting pressure on it, and to repair fractures and stabilize the spine. So they're trying to minimize that spinal cord injury. Once the spine itself has healed, then the rehab period begins, and they begin working on mobility and accommodating for whatever sensation has been lost. So there are functional electrical stimulators that can be surgically implanted that allow for some mobility. That's a fairly new thing. Exercises can be done for cardiovascular conditioning, but also if they have movement, we want them to maintain some muscle mass. If they don't, we want to do range of motion, passive range of motion to maintain joint health. There's a concept called neuroplasticity, and especially with really young patients, the neurologic system does have some ability. The nerves that are damaged or the nerves that are severed don't heal, but they may have some ability to accommodate for that and have other nerves take over for the damaged ones. And then they'll have PT, OT, and learn to use adaptive devices to maximize. We want them to have the maximum mobility and independence possible with their injury. Long-term patients with spinal cord injury are at risk for respiratory infection because they, if it's a higher injury, they can't breathe as deeply, so they're at risk for respiratory infection. If it's high enough, they can't breathe at all independently and they're ventilator dependent, also risk for pneumonia. They may have difficulty with temperature regulation. They need help with mobility. They're at risk for skin breakdown because of the immobility and the lack of sensation. Bowel and bladder function is often affected. They may either have reflex incontinence of the bladder. When the bladder gets to a certain point, it just reflexively emptied, or they may have overflow or retention, so the bladder never empties. It just gets really, really distended and eventually will start to leak. So they maybe are going to have intermittent self-catheterization to maintain bladder, to empty their bladder. The bowels also are affected, and so they, not only the mobility, but the innervation of the bowels is affected by the spinal cord injury, and so they're prone to incontinence and not incontinence. They may have some incontinence. They're more prone to constipation and impaction, which may lead to incontinence. So they may need, typically there's some kind of bowel program that involves either enemas or suppositories on a specific schedule to maintain bowel function. Some patients, in order to be able to be more independent, might have a colostomy, especially a low colostomy, because it might be able to irrigate that if they're wheelchair users, if they might be able to irrigate that easier than they can use an enema. We also have to help with pain management. So pain is maybe from the initial injury. They may have pain from the fracture, but also long-term patients with spinal cord injury, especially if they have a partial injury with spasms, will have pain from the muscle spasms and neurogenic pain. We need to be looking at the complications of immobility in all body systems. So think about lungs, think about skin, think about bowel and bladder, think about blood clots. Especially in the acute phase. We need to be able to recognize and manage autonomic dysreflexia, and we need to teach that patient and family how to recognize autonomic dysreflexia. And then we need to help that patient in adjusting to their life change and developing independence.